63 years male came with chief complaints of left loin pain since 7 months. The pain is continuous.
Sorry, slides are not visible.
Wait, it will come, it will come.
Yeah, it's now.
Correct. 63 years male came with chief complaints of left loin pain since 7 months. And the pain is continuous, dull aching and relieved by taking medications.
Whether it is radiating or non-radiating?
Non-radiating.
Is it associated with fever or trauma?
No.
No. And this patient has any past history of dysuria?
Possibly right PCNL was done 10 years back.
Okay. No. Any history of a urinary tract infection or fever with chills or hematuria?
No.
For 7 months. Fever with chills. 7 months history.
Like recently or recently.
Yeah, but if it is there for 7 months, that whatever that etiology is for 7 months, right? So fever with chills can't be continuous. Maybe episodes or whatever.
Any history of a lower urinary tract symptom patient has?
No.
No. Any history of abdominal fullness patient is complaining?
No.
No.
This fellow had a PCNL, no? He was told, you were told? He had a PCNL, no?
Yes, sir.
10 years back. You got that history?
Yes, sir. Yes.
Right. So what is the risk of stone formation? If I have a stone in my right kidney and it was removed 10 years ago, what is the risk of stone formation now?
There's 50% chances of a stone recurrence in 10 years.
How much?
50%.
50%. What? Over 10 years? Yes.
50% in 10 years. Anybody else wants to tell me?
Yeah, every day you fellows are doing stone, when right, left and center you are doing URS, PCNL. This is the answer you should have on your fingertips. Patient will ask, no? Okay, let me phrase the question slightly differently. I have two people. One has got a stone, the other does not have a stone. What is the risk of stone formation in both these patients? One fellow has got a stone, one fellow doesn't have a stone. Both are the same age.
Google देख लिया no?
And one fellow has got a stone which has been removed. The other fellow never had a stone. What is the risk of stone formation in both these individuals?
Go ahead, sir, question.
Okay, next class. Epidemiology of stone disease and stone tests. Scholars will know all this. Dhadadhad, URS kar rahe ho, ye kar rahe ho. Stone recurrence. Next week.
Yes, sir.
Show with graph. De novo stone, recurrent stone, unilateral stone, bilateral stone, all. Huh?
Okay.
Right. So carry on with this case.
No, any history of a LUTS is present?
No.
Any history of taking the
Sorry, any history of?
any surgical intervention apart from PCNL done in the past?
No.
Then any history of tobacco chewing or smoking?
No.
Any past history of tuberculosis or hypertension patient has?
He is a known diabetic and hypertensive.
No past history of tuberculosis.
No.
So
Any
if a patient has a past history of stone disease and loin pain, now with all this history, they know this, know that, what do you think is the problem?
it may be a it may be a recurrent.
You have to talk loudly.
It may be a recurrent stone.
Recurrent stone causing loin pain. Okay.
Recurrent stone means what? This patient never had a stone as far as we know on the left side. He had a stone on the right side. So you can't technically say it's a recurrent stone.
Sir, it may be stone on the.
This is, if it is a stone, it's a new calculus. Oh, occurrence.
Calculus in the left side now. Or it may be maybe there. Then third, left lung pain, totally
Too much of disturbance here. Too much of disturbance. Some wire or something is going further.
Sir, your voice is breaking.
There was too much of disturbance, static sound.
Okay, sir, we'll check.
Sir, now it's clear.
Okay, better. Yeah. So what was, we didn't hear that. What was your first diagnosis? You said Madam asked you?
Sir, renal calculus on the left side.
Okay.
Second, differential, maybe sir, PUJ obstruction or patient is of old age and history of left pain since 7 months. One of the differential maybe sir malignant, upper tract malignancy sir.
Did you ask any symptoms to support malignancy?
One patient is no history of smoking or hypertension.
Yeah, so it is no, na? Anything in favor of
any history of a weight loss, cough or hemoptysis patient has?
No, sir.
No. Occupation, like what patient did?
Farmer.
Yes, he is old age and he has a left loin lung, but long duration of pain. One of the possibilities may be malignant. So these are
You said PUJ obstruction, huh? You said PUJ obstruction.
Yeah, he said.
Yes,
One
sir.
of the differences was PUJ. How did you hit upon that diagnosis, PUJ obstruction? You think it happened after the PCNL was done, or was it missed at the time of the PCNL, or the surgeons who did the PCNL would have noted? No, they would have done some imaging before PCNL. People do some functional assessment. They would have said. And suddenly, in 63, how suddenly it became apparent that he's got PUJ?
No. While doing a right PCNL, we will image both the kidneys, no? So if there is PUJ, won't have been noticed. That is what sir is saying. Why it was unnoticed?
10 years just sitting on it. You also said it could be a stone, no?
Yes, sir.
That is why I asked you the first question. That's why those answers must come next week.
Yes, sir.
So what are you left with now?
Sir, examination, I guess.
What other diagnosis are you left with now?
These are the differential I keep in my mind.
You are assuming it is renal, huh? Are you assuming it is renal?
Sir, I want to ask whether any history of headache or palpitation patient has or sweating? Yes.
No, sir.
No. Sir, most likely of renal origin, I will keep these three in differential and examine the patient. Sir.
No, what I want to tell you is just because we are urologists, we tend to focus only on the kidney. But to have a wider expose of conditions there, you must not forget that we've got adrenal sitting there, we've got the retroperitoneum there. It could be anything, no? So it's good when you are asked to give the differential diagnosis. Say it could be renal, it could be extrarenal. Extrarenal could involve the adrenal or any structures in the retroperitoneum. All this can give rise to left loin pain. It's vague left loin pain for 7 months. It need not all the time be urological. Okay? ठीक है, examination बोलो.
The vague mass is general examination. Patient is only central lobe obesity. On abdominal examination, vague mass is palpable in the left lumbar region, which is hard in consistency with ill-defined borders.
How can a mass be vague if you say it is hard?
So borders are unable to.
If it is vague, how do you know it is hard? It's vague, it is vague.
Sure.
That means if you say it is hard, there is mass is there.
Sure.
Isn't it? I'm just looking at the way you've written this slide.
Sure.
If I feel a mass and it is hard, it is there. It's not vague.
Sure.
So you either say it is a vague mass, and it cannot make out the consistency.
Sure.
Or there is a mass and it's hard in consistency. Full stop. That's it.
Sure.
Huh? Okay.
Sure.
Vague is ethereal. It's in space, in cloud. Don't know what it is. So are you saying that there is a mass? Because it's important for him to know.
Yes, there is a mass.
There is a mass. Full stop. Okay. There is a mass.
Hard mass, borders are not palpable.
No.
Okay.
So what do you want to know for this mass? Only whatever he has told you are happy with?
No, ma'am.
Then you ask, huh?
With the mass, can you tell the extent of the mass the quadrant is occupying and whether it is moving with respiration or not?
He has a central obesity. The fullness and mass is not seen. So only in palpation we can able to palpate the vague mass with ill-defined borders.
And whether any skin changes are there over that?
No.
Sorry?
No changes.
No changes. Any
What
dilation?
skin changes can happen over a lump? Unless it is infective or something, which he doesn't have a history of fever or chills or anything. What skin changes can happen? You want to ask something relevant, no? Okay, extent is fine. Which quadrants it is palpable is okay. What else do you want to know? Or you feel best is to do a CT?
Any dilated veins in the flanks?
No.
No. And genital examination?
Normal.
Normal.
So what's your summary now?
The 63-year-old male with a left flank, a 63-year-old male known tobacco chewer and smoker with a known case of hypertension, with a pain in the left groin region and with examination large lump hard lump palpable in the left upper quadrant with ill-defined borders. Sir, I would like to my most first differential diagnosis would be malignancy of the upper tract, sir.
What do you mean malignancy of the upper tract? Specify here.
Sir, probably of renal origin, sir. I will consider that as a first differential.
Renal mass. Okay.
Why not adrenal mass?
Ma'am, history-wise, the patient has no symptoms pointing towards adrenal, like no palpitations or headache.
Why not the colonic mass?
It may be, but the history is most like, ma'am, patient has no altered bowel habit, no constipation or melena.
But we
And
didn't ask for it. Why not? It's not the spleen.
ma'am, they said the mass is only in the upper quadrant. If we just splenic mass, it is from the upper. If it's a large mass notch, we could able to
No,
palpate.
but he has central obesity. They can't palpate properly. That's what he told you, no? When you started asking him about the mass. He said he's obese and I can't tell you much. Everything can be there, no? If it is in the left upper quadrant.
I would like to investigate further, ma'am, for confirmation of diagnosis. I would like to first do the urine routine microscopy, serum creatinine, hemoglobin, total leukocyte count, and of the patient.
The slides are not changing.
Hello?
Sure.
No?
Slides are not changing, sir.
Don't keep it on PowerPoint, just keep it on this. No. So it takes a long time to
Hello.
found it out long time back.
Hello.
Ah, yeah.
We are
Yeah.
seeing.
Now changing. Urine routine microscopy.
Who is discussing the case? Adil. Who is discussing?
Aadhaar.
Sir, Aadhaar.
See, you have a left loin mass. So when you are discussing the differential diagnosis, you have to, as I said earlier, say renal and extrarenal masses, and with that you ask the history so that you must give all the diagnoses that are possible. I know in your mind you will say that it's all renal only, but I think for the exam purposes, you must mention what I told you earlier so that you are in the clear about all the differential diagnoses of lumps that occur in that area.
Okay, sir.
Because there is no specific history here. If there was a history of hematuria, then of course you can point to the kidney. But it's just vague left loin pain. But if you look at the statistical chance, loin pain and mass with or without hematuria is equal to RCC unless otherwise proved.
Okay.
That's a given. I mean, even Hamilton Bailey says that. If all three are there, the chance is very high. But if two are there, 2 out of 3, that is also a high chance. So we all agree that it has to be renal malignancy as the first choice. But there could be surprises.
Yes, sir.
What is the percentage of adrenal masses which are functioning? What is the percentage of adrenal masses which are functioning?
Sir, 4 to 5%, sir, functional mass.
What? 4 to 5%. Next class also. Add this to the list of things to discuss. Very good. Chalo, carry on. So what will you do now?
Sir, I would like to do the radiological imaging in the form of contrast enhanced computed tomography of abdomen and pelvis, sir.
Okay. Right. Creatinine is normal.
Yes, sir.
Are you able to see the slide?
Yes. Next. Next. First CT is only showing. Slides are not moving. No, can you go back? Fifteenth one, yeah. 15th one. Next, yeah.
There are 3 and 4 patients.
Next,
There, they have denied or refused initial treatment.
next,
Mass will become apparent anyway. And we have one documented evidence, late 10 years. Still no mass. No, we have also done some. This will also level.
next,
Insulin has metastasis to organize outside. That was like the health is spreading.
next, next,
The problem with the staging earlier was that
next,
last over novels are extremely motivated on this.
ma'am, this is a contrast enhanced computed tomography of abdomen and pelvis. With right side of the kidney appears normal in size, shape.
Is it normal?
Minimal PCS fullness is there, ma'am. And while left side of the kidney is enlarged, there is a large heterogeneous mass arising from the upper.
No, you talk about the right kidney. Is the right kidney totally normal? Minimal fullness, you said. What about the?
There are lots of things. You see, when the examiner asks you the question twice like this, it means that you have not answered fully. So think again. Madam asked you, is it absolutely normal? So what are the things that you will look at in this kidney? Remember, this is a kidney which had a stone 10 years ago.
Yes.
PCNL was done. So the first thing you have to see is whether there is a recurrent stone. On the right side.
No evidence of.
No, you have to mention all this. Then you look at the functional status of that kidney. Is there evidence of scarring? What has happened to the Gerota's fascia? Can you see it? Is there stranding? All those things you have to talk about. Then you talk about the PCS. Before you get to the PCS, you must know what is the function of this kidney. Is it excreting contrast? All that you have to tell. You just said right side is normal. But I think in the exam, it is important to rule out, mention some of the relevant negatives. You will get more marks. Examiner will say, yes, this fellow is thinking.
Can you go back?
See, if you did not want to, or you are not sure about the right kidney, what's happening to the ureter, how is, then you talk about the mass, no? But you can't say it's normal and just push off to the opposite side when it is showing so many things which are not normal. That's what caught my attention, that you have not had a proper look. They have pointed out also, no? Can't you see? This patient is diabetic, hypertensive.
perinephric fat standing is present now. No evidence.
What's happening to the ureter? Is the PC system dilated?
PC system is dilated. Upper ureter contrast excretion is there, but lower ureter is not.
What is that structure around which it is curving?
Lymph node, one enlarged lymph node is there now. It is.
Lymph node. What else could it be? Only possibility of lymph node. And why lymph node on right side? And that too lower down at that level? L3, L4, L3 or L2. What else could be that structure? Follow it up. See? Yeah, it could be the IVC also. Okay, talk about the left side first.
There is a large heterogeneous mass arising from the upper pole and interpolar region of the left kidney with the area of necrosis seen.
Now here you need to mention size. Now nothing is vague. Okay.
Of approximately 8 into 8 centimeter mass from the upper and the middle pole with area of necrosis, mainly ectophytic mass with perinephric fat standing seen and perinephric fat standing seen and it pelvic elastic system.
No. Finish the mass. Then you go to pelvic elastic system. There are certain things that automatically should come out in your presentation when there is a mass in the kidney. For all practical purposes, when you have an RCC and there is evidence of necrosis, you only mention the fact that there is some perinephric standing. Can you see the Gerota's fascia all around? Is there any involvement of the Gerota's fascia? Can you see the adrenal gland on that side? Is there neovascularization? Apart from necrosis, is this a vascular tumor? All those things you have to mention. And then, these are all automatic things that have to come. You can't just say that there is a mass there, which is all the features which will substantiate that this is a classical renal cell carcinoma type. If it is not, then you put the negatives against it. All right. That's how you will work it. Then you go on to the function of that kidney. Finish the mass.
The large mass crossing the polar lines and extending up to the Gerota fascia with area of necrosis present, and the perinephric fat standing is present with the enhancement also seen in the enhancement scene.
What is the location of this kidney?
Sir, it's arising from upper and
location of the kidney. Is the kidney located normally?
No, sir, it's down. It has been pushed down, sir.
What is the importance of that question? What is the importance of that question if the kidney is pushed down? You are seeing that the lower pole of this kidney is lower than the lower pole of the right kidney.
Sir, it involves large mass arising from upper pole, which may involve which is involving adrenal also, sir.
Can it be separately an adrenal mass itself?
Maybe, sir. It's maybe an adrenal mass.
So you'll have to, mention these facts as they are seen on the X-ray because it's important. But then you have to look at the individual features of the mass on the CT, on the axial cuts to see whether it is primarily arising from the kidney or is it arising from somewhere else. So that is the importance of looking at the axial cuts.
आकाश वो जरा लिवर डिस्ट्रीब्यूशन को देखिए
Okay, sir.
उसका प्रॉब्लम एपिगैस्ट्रिक लिवर डिस्ट्रीब्यूशन चल रहा है ना तो आई थिंक गुजरात का एक रेसिडेंट है मुंबई का है और पुणे का है प्रांजल है सेंट मी मैसेज दैट ही वांट्स टू टॉक प्लीज जस्ट हैव अ लुक नाउ तुम्हारा मेल स्कोर में देखना चाहिए
You understand what I'm saying? Sir.
Yes, sir.
Okay. So it's very important to look at this.
Okay, sir.
You look at the pathology of the kidney when you know the gross, what it looks like, and translate that same thing onto the image. The pathology books will tell you all that, no, highly vascular tumors with areas of necrosis and this and that, everything is there. Except for the color. Everything else is there.
Yes. Sir,
You think this is a renal mass or is it adrenal mass?
sir, most likely it is a renal mass, sir, from the upper and the middle pole, sir.
Okay.
Then, sir,
Is there anything else you want to tell us?
the
That is important?
pelvic elevation system is normal, sir. Renal vein and the IBC appears to be normal, sir.
Anything else you want to tell us?
Excretion of the contrast is there, and ureters is dilated, but no thickening is present, sir. Bladder appears to be normal, sir.
With reference to the mass, such a large mass, anything else which is important to mention?
Yes, sir. Okay.
TNM.
Sir, no evidence of lymph nodes or the any metastasis.
Such a large mass, what is the risk of lymph nodes? So one more pointer for next class. Correlation between renal mass and presence of absence of lymph nodes. Okay.
hardly few malignancies. Why are we spending time in just description of renal mass? Now you'll be going exam going, no? Same things you just can't keep on unless if you get stuck here, how will you go to management? Grow up here, everybody.
So what will you do now?
Sir, I would like to proceed for.
Don't fear to see for metastasis. Other same thing like ABCD won't go.
Ma'am,
No?
is already.
Huh?
Liver and chest X-ray is normal, ma'am.
The chest X-ray you didn't ask. They just showed you before.
Sure, ma'am. Chest X-ray before.
Yeah, but they showed you, na? You have to ask, right? You want to know any other parameters, blood parameter? You just ask for HB, CBC and creatinine. You knew he is a diabetic, you didn't even ask for sugars. They showed you.
What about platelet count? Is there any
platelet count? Who is that fast?
Why is it important to get all these features when you have a patient like this? You wouldn't do all this in a patient who has a small renal mass, isn't it? When you have a large renal mass, the risk of metastasis is very high. The risk of it having poorer outcomes are high, and therefore to get those parameters which are poor outcome measures, you need to do certain investigations. So that is what we are asking, nothing more. That is why chest X-ray is done. That is why looking at the liver. That is why the platelet count is done. That is why your liver function is done. All these things are important parameters which will give you an idea as to how serious this matter is.
नहीं, but फोन करना चाह रहा है तो I'll ask him to call you then because.
What is the treatment now? Adar, what is the treatment?
Yeah.
Sir, if patient, I would like to do a sir.
No. What is your treatment choice for this patient?
Sir, radical nephrectomy, sir, I will.
Why? What is your hesitation?
Yes, sir.
No hesitation. Answer must come fadak. There is no question of doing any partial and all that. This is radical nephrectomy.
Yes, sir.
Will you do lymphadenectomy?
Yes, sir.
You will do complete lymphadenectomy.
Yes, sir.
That means left side, all the paraortic nodes, everything you will clear.
Yes, sir.
Right. So next class you will tell that also. Lots of things to clarify. You see, we said that today somebody is going to talk about RCC, no? In the morning, Madam asked who's presenting, and there was no taker. So we just by chance you have a case of RCC, and all these doubts have to be cleared.
Yes.
4 questions I have asked. Four doubts. All must be clarified next week.
Yes, sir.
Risk of nodes. Will you do nodal disease? Will you do nodal transection? Risk of stone formation, de novo, all that. Okay. And functioning versus non-functioning adrenal mass.
Yes.
Very good. The interesting thing about this patient is that 10 years ago, when he had this PCNL, we found a 3.6 centimeter mass in the left kidney. We told him it must be removed. And we said we will do partial nephrectomy for him. This man left things alone, and now it is 10 years. And you see the growth?
Yes, sir.
So what is the growth of renal masses?
The rate of growth.
Rate of growth of a renal mass. 1 centimeter.
No, 2.7.
Chalo, add 5. Question number 5. Question number 5 for next class. These are standard questions that we are expected to know. Also. Patient will ask. Will it grow? Will it not grow? This, that, all that. Anyway. Okay. So we'll stop for today at that point because a lot of unanswered questions.
Yes, sir. Yeah.
Next class, we finish these unanswered questions, then only proceed.
Okay, sir.
Hello.
Sir, are you